Are we good? That's it. All right, everyone. I think we'd like to go ahead and get started. Thank you all for attending both in person and online today's cardiovascular medicine grand rounds. Today we have the pleasure of hearing from two of our stellar senior fellows. First off, a little housekeeping. Here is the CME code 47797. And our upcoming schedule for grand rounds, heavily weighted towards fellow talks. We're excited about. And then into June, the Calabrese lecture and the Woody Lee honorary lecture. For purposes of CME, here are the disclosures. So it's my pleasure to introduce both Suveen and Imran today to give their grand rounds presentations. Suveen, I've known since just after you graduated from medical school, I believe, coming here to rotate with us as one of his first rotations in the United States, coming from All India Institute of Medical Sciences. He was able to parlay his 2-week block on white consults into a postdoctoral fellowship in core, during which he was very successful, and then on to residency at University of Missouri, Kansas City. We're excited to have him come back and join us here for cardiology fellowship. Imran came back to us at Yale after completing medical school here and then going on to residency at Brigham and Women's. So you see the titles of their talks here today. Suveen's on unexpected and serendipitous answers in cardiovascular research, and Imran's discussing the cardiology house staff educational curriculum that he's been defining with some of our faculty members. So I think, Imran, you're up first. Looking forward to hearing your discussion. Thank you.
Thank you for that introduction. I'm Imran. I'm one of the third-year cardiology fellows. Over the next half hour or so, I'd love to share with you some of the work I've been doing with some of the faculty members here and some of the residents and even the fellows. And hopefully I'll convince you that we have a formal cardiology house staff curriculum that we've been working on. And hopefully I'll convince you that this is something that's really important for our future. So the learning objectives for today. So we're going to explore the current medical education landscape for medical students, medical residents, and advanced practice providers. These are all folks that rotate with us through the inpatient services. And we're going to identify the needs for these learners on our inpatient rotations. And then I'll briefly go over some of the resources that are now available, thanks to a lot of the fellows that have helped out with this. And then we're going to focus on the future and discuss, the impact on learners and how we can assess the impact on patient outcomes. So, before I get started, I just want to point out there's going to be a pretty severe physician shortage across all specialties. So the National Center for Health Workforce Analysis projects a shortage of about 9,000 cardiologists by 2037. And in the bottom right, you can see a graph. The orange lines depict the demand and the blue line depicts the supply. And you can see that there's going to be a severe supply-demand mismatch for cardiologists. This holds true even for primary care physicians. There's going to be almost a 90,000 primary care physician shortage by 2037. And one piece of this puzzle is that's important and a center point is medical education, and it's important in this dynamic challenge. And I want to point out that habits and things that we learn in medical school will imprint on us, and they drive our practice in the future. So here's a slide showing essentially what the last slide had showed in terms of physician shortages, but this is broken down by geographic areas, and you can see this one's specific for primary care physicians, but the same story holds true for cardiologists as well. But areas in green are places where there's going to be severe shortages of primary care physicians by 2037. So with that in mind, Dr. Gallegos and some of the internal medicine residents and fellows got together, and we decided that we'd like to get together and produce a formal curriculum for cardiology education that can be used on our inpatient rotations. The reason we decided to do this is because medical education is constantly evolving. And there's a significant diversity in learners across various heart and vascular center inpatient rotations. So we frequently have medical students, advanced practice students, medical residents, and interns rotating throughout a lot of our services. And so we have to dedicate our teaching and sort of shape it around the learners that we host. One study of a Canadian hospital system found that there was significant case variation seen in an analysis of 793 senior Canadian internal medicine residents across 5 hospitals who saw almost 150,000 admissions over a 10-year period. And I think that just goes to show you that even in people in the same residency, you can sometimes see a wide variety of cases, and some people may not see a wide variety of cases. So some of these residents saw 3 times as many heart failure cases as other residents. So I'm going to briefly go through what the medical student curriculum looks like, what the advanced practice provider curriculum looks like, and what the internal medicine residency curriculum looks like to serve sort of a backdrop for why we're doing this. So Yale Medical students, I think Dr. Forrest and I both went to Yale Medical School, so it's changed over the last couple of years. So the first year and a half is basically preclinical coursework. And then in the middle of year 2, you go off to clinical clerkships. And then in year 3, in the middle of year 3, you start doing sub-I, you start doing electives, and you start doing research. It used to be that the step 1 and step 2 exams were done. So step 1 was done at the end of your preclinical coursework, so in the middle of year 2. But now it's done in year 3 at the end of your clerkships. And then your phase 2 clerkship period involves clinical clerkships, sub-internships, electives, and research. I'm going to go over some of the changes to the U.S. medical licensing exams, which I think has changed quite a bit over the last 5 years. So as I mentioned, the old curriculum, step 1 and step 2 were done at the end of the first 2 years. Step 2 CK and steps 3 were done sometime after that. Now in the new curriculum, step 1 has become a pass-fail exam, and step 1 and step 2 are done anytime after January and 3rd year. And notably, step 2 CS, which used to be a clinical skills exam that was done either in Chicago or Philadelphia or Atlanta, is now permanently discontinued as a result of COVID. This is the Yale Physician Associate Program. This is somewhat similar to the medical student curriculum. Years 1 and 2 are years 1 is largely a preclinical curriculum. Year 2 is more focusing on the clinical aspects. And then I'd like to share quickly with you the inpatient team structure across various services. So White Consults has a fellow and attending, and oftentimes there will be a visiting medical student and sometimes a visiting resident. And then there's oftentimes a PGY1, PGY2, PGY3, and sometimes even advanced practice students. And then on the Goodyear team, there's typically 2 medical students, 2 interns, and 2 residents. The blue teams will pretty much always have 1 PGY1 intern and 1 PGY2 resident. And then the SRC and VA consult teams are often quite variable, but typically they'll have a medical resident anywhere from PGY1 to PGY3 level, and sometimes even an advanced practice student. So I think you guys can appreciate that there's quite a large variety of learners that rotate through a lot of our services. The internal medicine residency curriculum includes didactics. They have a morning report, they have medical exam rounds, they have noon conferences, they have ambulatory medicine didactics, they have an ambulatory education system, and then they have various inpatient rotation services. And then they take the ABIM boards after they graduate from residency. Importantly and uniquely, residents carry a dual role, which I think medical students really don't experience, and that is they're both learners and employees, and that's something that we have to keep in mind. And then we have fellows and attendings, and we have to be mindful of all the responsibilities that they have to balance. So attendings have inpatient clinical responsibilities. Then they're often managing their outpatient panels, which includes responding to inpatient baskets or in-basket messages. And they're also reading EKGs, and they may be involved with research and other meetings. So they have a lot on their plate, and that makes teaching sometimes difficult. And then Goodyear Fellows often will be involved with ED consults and triage. They'll be taking sign out from the CCU on patients who are getting transferred, and they'll be managing their own patients on Goodyear. So with that in mind, we decided we needed to do a little bit of an assessment to figure out what exactly the needs of the learners on these services were. And so this is some work that was done by Natasha, who's here with us. She is a rising internal medicine chief, and she did some work on trying to assess what the needs of the learners on these services are. So she used Slicer, Dicer, and JDAT analytics, and she used resident surveys to identify what the primary diagnoses on these services were and what resident preferences were in terms of how they preferred learning. So here's some data. She looked at all hospital admissions from July 2020 to November 2023. We identified almost 600,000 hospital admissions, and these patients were admitted to either the medicine Goodyear team, the cardiology white team, or the blue team. And we evaluated almost 13,000 primary encounter ICD codes. And what we found was that the large majority of the ICD codes that were getting admitted were NSTEMIs, paroxysmal AFib, and then a little bit of a mix of other things, including hypertensive heart disease, chronic kidney disease with heart failure, and unspecified chronic kidney disease. And if we limit that to the top 16 diagnoses, we see the following. So none of this should be surprising. Top one's probably the top one being ACS. Then there's atrial arrhythmias, hypertensive heart disease, heart failure, chest pain, coronary artery disease, ventricular arrhythmias, aortic valve stenosis, AV block, cardiac devices, cardiomyopathies, pericardial disease, complications of MI, SVT, sick sinus syndrome, and rheumatic heart disease. So we then moved on to assessing the needs of learners. And what we did was we sent out a survey to a lot of our medicine residents and had them answer a couple of brief questions. So the majority of respondents were mostly PGY1s and PGY2s, couple PGY3s. And one important question we asked them was, what form of learning or teaching did they participate in during their rotation? And so a lot of them had experienced or had teaching that involved the use of a whiteboard, bedside teaching, PowerPoint-based lectures, and some of them even did independent study. And then we also asked them how much time did they spend on teaching. And the majority of them got about 10 to 30 minutes per day or 30 minutes to an hour per day of teaching. And then we asked them how satisfied were they on the Goodyear rotation in terms of the cardiology curriculum, and the average was about 8. And then we asked them, most importantly, what their preferred style of learning was on these rotations. And the overwhelming majority preferred lectures using a whiteboard or case-based discussions. Fewer preferred bedside teaching, and some prefer just having a framework provided for them. And you'll notice that very few of them prefer the Socratic style or pimping. And then, we did a quick survey of what topics were covered. And as you can imagine, again, chest pain, heart failure were covered in quite detail here, it seems like. But things like arrhythmias and rheumatic heart disease and other arrhythmias were not covered to the same extent. So we asked them how confident they felt in evaluating each of these diseases. And you can see that most of them felt pretty comfortable managing heart failure and ACS, but less of them felt comfortable managing ventricular arrhythmias, supraventricular arrhythmias, and heart block. And finally, we asked them which topics that they would like to see included in a formal cardiology curriculum. And there was quite an arrangement of responses here, so this wasn't that helpful for us. So we asked one final question, and based on the division of all of our teams, is there a difference in case mix of Goodyear versus Blue Team versus White Team? White Team being the primary inpatient consultative service, Blue Team being more of a consultative service for the emergency department, and Goodyear more focusing on being an inpatient rotation. So for the Goodyear team, the top diagnoses were NSTEMI, AFib, pretty much all the same things we had seen before. And then what we saw with the Blue team was, again, quite the same diagnoses, but sepsis somehow made its way in there. And then the thing that we saw with the White team was that it was kind of the same array of diagnoses, but there was far less diagnoses coded. So in the bottom left, you'll see that there was, for hypertensive heart disease, only 7 diagnoses coded for that, and everything else is around a level of 2 or 3. So for whatever reason, White team consults maybe are not being coded appropriately or not getting coding at all. So I want to transition a little bit and just summarize all of the data that we've seen. So the key takeaways from this is that residents prefer formal didactic sessions and case-based discussions. They feel less confident, or they feel quite confident managing heart failure, chest pain, ACS, and they feel less confident with arrhythmias, particularly SVTs, VTs, and bradyarrhythmias. And Goodyear, Blue Team, and White Team appear to provide a similar experience in terms of the variety of conditions that they manage. Of course, this is limited by accurate ICD coding, but we think that this is a good representation of what fellows, what attendings, what residents, and other learners on these teams see. So with that in mind, we decided that it'd be important to go ahead and try to develop a formal curriculum where we would have our own set of slides that would incorporate guidelines and that would incorporate other teaching methods to facilitate a rich learning environment for a variety of learners. Our other alternative goals were to provide education resources in a busy and demanding clinical setting. And we, like I said, we want to utilize national and local resources and guidelines, particularly the Yale New Haven Hospital Care Signature Pathways. And finally, we wanted to improve patient outcomes in a rapidly evolving specialty. So these are the topics that are currently featured in our library. So the ones in green are slide decks that are already available that can be used on Goodyear, White Team, Blue Team. So we've got supraventricular tachycardias, we've got atrial fibrillation, ACS and chest pain, heart failure, evaluation of syncope. This was a request of Dr. Posick in particular. Then we have ventricular arrhythmias, preoperative risk stratification, which was not something that was coded for by the White Team attendings, but that I, as a White Team fellow, felt was quite important since we see quite a bit of that. Things that are in progress right now: structural heart disease, bradyarrhythmias, and then what we have planned for the future includes evaluation of dyspnea, hypertensive urgency, and emergency. What are the strengths of our house staff curriculum? So it's a multidisciplinary team of authors and reviewers. So we have heart failure attendings, non-invasive attendings, electrophysiology attendings who've all contributed to the slides and reviewed them. We also have pharmacists, and we also have some fellows. The other notable thing is that a standardized curriculum improves educational equity. So everyone receives the same training and everyone gets to sort of see the same slides. These are easily accessible through Microsoft Teams, which I'll show you in a moment how to access. These are living documents that can be easily updated by anyone with editing rights, so particularly attendings and fellows. And for a lot of these, when available, we've integrated the Yale New Haven Hospital Care Signature Pathways, which I think is very useful. So I'll quickly show you how to access the library. So if you just go to teams.microsoft.com and you use your Yale login, not the YNHH login, you'll have access to the Yale Cardiology Fellowship teams. And then when you go there, there's a house staff education channel. And in the top where you see files, you'll be able to access all of these. So what are the features of the core topic slide? So we go through all of the guidelines that are relevant. We give examples of relevant imaging, EKGs, and diagnostic algorithms. At the end, we have case-based discussions. And then, as I mentioned, we've integrated the care signature pathways. And oftentimes, pharmacists have added some particular insights that they have, such as pharmacy resources. And we also highlight transitional care resources, such as the heart failure disease management program. Each of these slides should ideally be covered in about 30 to 45 minutes, which we feel is something that can be easily done during a day on Goodyear, on white or blue team. And then some of the limitations and future directions of our work. So we'd like to, in the future, hopefully assess the impact of our curriculum on learner outcomes. So this might be something we could do with pre or post rotation assessments. And then we'd also potentially look at patient outcomes and maybe 30-day readmission rates before and after implementation of this. Notably, this is not a replacement for bedside teaching. Other things we'd like to work on, as I mentioned, hopefully expanding the curriculum, potentially working on a POCUS curriculum, and maybe adding a selection of mixed-app questions. With that, I'd like to just give a big shout out to our team. So Sezia for guiding us through all this work, Dr. Posick and Dr. Nudell, who've also been excellent mentors and who've always been willing to chat about the project. The faculty content reviewers were also instrumental. So Dr. Clark, Dr. Marai, Dr. Levy, Dr. Gallegos again. Fellow reviewers, so Kene, Israel, Catherine, Wright, Sarah were also very helpful. Natasha was amazing in doing all the sort of the background work. Derek Lynn and Corinne are also medicine residents. Derek, I believe, is going to be doing cardiology fellowship at Brown. Natasha is going to be an internal medicine residency chief. And then I think she also wants to do cardiology. And then Maybell is one of our amazing heart failure pharmacists who also contributed to a lot of our work.
I think we should do questions at the end to ensure that Suveen has time for his presentation, then we'll bring things back together. This wonderful presentation. I think there is one diagnosis that you're missing, but that's a
Slides.
Suveen, we're excited to hear your talk on unexpected answers and serendipitous findings of cardiology research. Thank you.
Right. Welcome, everyone. Okay, great. Well, hello. My name is Suveen. I'm a third-year fellow here at Yale, and I'll be presenting unexpected answers and serendipitous findings in cardiology research. I don't have any disclosure, but I do have one thing to disclose. The original plan was to present the work that are done on machine learning and risk prediction with Harlan and Rohan, but I thought to do something different because those things have been debated, counseled, talked about over and over and over again. And talking about learning, let's talk about things that are opposite of data processing, some things that the researchers didn't mean to find in their research studies, but ended up finding it, and that kind of changed our practice. And the reason I'm doing this talk is because of one person. Who knows Caitlin Upton? Anyone? Not Kate Upton, the actress, the Caitlin Upton. Maybe this rings a bell. No. All right, so she was a contestant on Miss America teen pageant, and she was asked a very simple question, and the answer was just spectacular, to say the least. He knows. So the question was, recent polls have shown a fifth of the Americans can't locate the US on a world map, and why do you think that is? And let me see if we can play the video.
Okay. Recent polls have shown a fifth of Americans can't locate the US on a world map. Why do you think this is?
I personally believe
that U.S. Americans are unable to do so because some people out there in our nation don't have maps, and I believe that our education, like such as in South Africa and the Iraq, everywhere like such as, and I believe that they should, our education over here in the U.S. should help the U.S. or should help South Africa and should help the Iraq and the Asian countries, so we will be able to build up our future for our children.
Thank you very much, South Carolina.
Hold on to that, right? So I personally believe that the US Americans are unable to do so because some people out there in our nation don't have maps. And I believe that our education, like such as in South Africa and the Iraq, everywhere, like such as, and I believe that they should, our education over here in the US should help the US or should help South Africa or should help the Iraq and the Asian countries so we can be able to do or build up our future. Now, people laughed at it. I laughed at it when I saw this. But to just think about it, it's the perfect answer. She answered why US Americans cannot locate US on the maps by giving the perfect answer. So let's go through the history, talk about the studies which wanted to answer something, but in their own unique way ended up answering something else, which later made more sense. All right, so let's talk about UK 92,480. It's a compound. It looks like this. And this was developed by Dr. Simon Campbell under Pfizer UK as a potential breakthrough drug for hypertension and angina. And they formulated it and developed it in 1989. So the initial evaluation of this particular compound enrolled 8 patients. No, it sounds less, but that's what they did. They just wanted to test it out, and then they enrolled 8 patients in the study with stable angina. And then the systolic blood pressure only dropped by 8 millimeters of mercury. So not a lot what they were expecting. They were expecting a much higher drop, something on the counts of 25 to 30 millimeters of mercury in these patients. And they did not have any effect on angina, but only 8 patients, right? And of course, they did not publish this study or any findings from this initial workup. However, they did find that there was a 25% decrease in pulmonary pressures in these patients, right? And they also found something else, which was pretty serendipitous finding. Some of you might have guessed what that is, but let me refresh or go through it one at a time. So it acted on the PDE5 and inhibited that, acting on the CGMP cycle. Any guesses what that caused for this? Cause reduction in all 8 patients. So something that they developed for hypertension and stable angina had a completely different effect, which they were not anticipating. So they ended up renaming UK 92,480 to sildenafil. And what they did was then they pivoted their whole research funding of this drug for stable angina and hypertension to for sildenafil research for erectile dysfunction. And then they published this paper in New England Journal of Medicine in 1998. And it showed pretty impressive findings. If you look, what they're showing is mean domain score of the erectile function at baseline and towards the end of the study for placebo and sildenafil. And you see just a remarkable increase at the end of the study with sildenafil compared to placebo. And the same thing was seen not only for erectile function score, but also the frequency at which the intercourse was attempted. So stable angina, hypertension, pivoted towards erectile dysfunction. And now it is one of the most prescribed drugs in the US and in the world. And probably like $2.9 billion estimated market share of Viagra. It's shown that the projections continue to grow in the global market pretty steadily. I thought that was fun when going through it. But remember the 25% drop in the pulmonary pressures? Well, of course, they're going to do a trial on that as well. What they did was called a super trial, where they use the sildenafil citrate therapy for pulmonary arterial hypertension. I'm just going to show one particular figure from it, which I think is extremely impressive, is the 6-minute walking distance. And it just shows a tremendous improvement with escalating doses of sildenafil in the patients who have pulmonary hypertension. All right. So let's go back in time. This was a pretty new study. Let's go back to 1628. Actually, let's go back further to 129 AD and talk about this guy, Galen. Anyone knows who Galen is? Yeah? Oh, yeah, of course, Dr. Velasquez. He was a physician to the Roman Emperor Marcus Aurelius. And he was the first person documented in the history who gave the concept of blood circulation. And it's very interesting because you can read his work at Yale Beinecke Library. They have access to it. His theory about blood circulation is that the veins contains all the blood. All veins originate from the liver. The liver produces fresh blood continuously and pumps to the body tissues. And then the tissues consume the blood completely, making it a one-way circuit. Now, this was back in 129 AD. And the fascinating thing is that this particular theory of blood circulation persisted till 1628. So 1500 years, the physicians were just working on this one-way circuit theory and practicing medicine based on that, and also developing newer therapies in the golden ages. Till this guy shows up. He is Mr. William Harvey. He was a very renowned anatomist and physician, and he was particularly known for his work on dissection and vivisection. Vivisection is surgeries on live animals. That's how they studied physiology and anatomy back in the day. And he was working on a paper where he was performing a dissection on blood vessels. And then he discovered this. Anyone what that is? Right. That's a vein, and that's a valve, the vein valve. So nobody had found vein valves back then, but he was the first one who showed that there are valves in the vein. But then he saw something else in the structure of the valve. Like, based on the structure, the blood was flowing in this direction. But it's supposed to flow in this direction based on Galen and everything that we've been practicing. So why is blood going in the opposite direction? So he did multiple experiments. And I think one of the best, simplest experiment that I've ever come across was published in his book, De Motu Cordis, in 1628, which you can also access at the Beinecke Library. And it is extremely simple. He took 5 really muscular farmers, and then he put a tourniquet on their biceps. And then he popped up their veins and then occluded the vein proximally and then drained them distally and then let it go. And he could visualize that the blood is flowing towards the body rather than away from the body in the tissues. And this is the first time in the medical history that we had a closed circuit blood circulation, all the first time ever. And then the cardiology, as we know, changed. The medicine, as we know, changed, just because he was doing something else, but ended up finding something completely different. And then he was not even a physiologist. He just gave the whole subsequent papers on blood circulation and physiology, which was very interesting. So, talking about history, let's get back to year 2008. Something that is very near and dear to everyone here is the 2008 FDA guidance on evaluation of cardiovascular risk of new glucose lowering drugs. Sorry. Right. So the FDA gave these guidelines for new diabetes drugs. So the first thing was patient selection should include high-risk population, including the elderly and those with advanced cardiovascular disease, some degree of renal impairment. They required cardiovascular mortality, myocardial infarction, and stroke as their outcomes. And then the cardiovascular events must be adjudicated in a blinded independent process. So after FDA released these guidelines in 2008, researchers started working on implementing these policies in their work. And one of the first trials that came out just for looking at the safety and as well as the efficacy of diabetes drug in cardiovascular mortality was EMPA-REG outcome trial. And these are the results from the EMPA-REG outcome. Right? So what they found was the primary composite outcome. They found that empagliflozin did have significant improvement. But look at the death from cardiovascular causes and then hospitalization for heart failure. They did not plan to include hospitalization from heart failure in their main results because it was not, in the policy of the FDA. But then they saw 35% relative risk reduction. That's huge for something that they just found incidentally. Right? And then, of course, there were other trials. There was dapagliflozin and cardiovascular outcomes in type 2 diabetes. And mind you, these are not heart failure trials. This is just profiling what FDA wanted all the diabetes drug to be. And lo and behold, they also showed the same thing. Improvement in, they did a composite of cardiovascular death and heart failure hospitalization, but pretty significant separation in the survival curves in these patients as well. So if they combine the data of these trials, what they found was that there was a reduction in the cardiovascular death and heart failure hospitalization. There was significant reduction in all-cause mortality with a number needed to treat 11, 19 for CV deaths, and 16 for all-cause mortality. But also there was patients with HFpEF that they were seeing some signal improvement. And there was a signal for decreasing cardiovascular deaths and heart failure hospitalization in these, and 24% reduction, relative risk reduction in the heart failure hospitalization in patients with HFpEF. So the stage was set. And then there was a flurry of trials that came through, starting with the EMPA-REG outcome. And then, as you know, like there was DAPA heart failure. The EMPEROR trials came up later in 2020s. So, you had DAPA heart failure, you had all these trials come in, and which showed that the SGLT2 inhibitors were significantly improving mortality and cardiovascular outcomes in patients with HFrEF and HFpEF after the EMPEROR PRESERVE trial came in. And now you have all these newer guidelines, which include SGLT2 inhibitors as a standard of care, standard of therapy in patients with heart failure, something that FDA never had imagined when they were putting out those policies. They just had those policies because diabetes is a risk factor for cardiovascular mortality. And if you look at the subtext, they were doing it primarily for coronary artery disease. They never had imagined the heart failure population would be the one that would gain such a dramatic change in practice. So that was pretty interesting. Now, we're going to shift gears just a little bit and go back to 1940s, which was a pretty pivotal year. It had the first establishment of NATO alliance. The Russians tested the first nuclear weapons. The People's Republic of China came into existence with the Communist Party. And then tonsillectomies were being performed in 1940s as well. One of the ENT surgeons back in 1940 was Dr. Rudolf Singer. And he was an army captain and a surgeon. And what he was trying to do, he was trying to optimize the perioperative management for tonsillectomies. And he used a very historic drug that had already been in circulation, a drug extracted from the bark of a willow tree. Any guesses what that drug might be? Oh, good one. Maybe a glycoside. All right. So Dr. Rudolf Singer published this report back in 1949. And it says, acetylsalicylic acid, a probable cause for secondary post-tonsillectomy hemorrhage, a preliminary report. Aspirin. Right? And it's interesting because how he came to the conclusion, all he was trying to do was manage post-operative pain and develop a regimen for post-operative pain in these patients. He notes that in my experience, the abnormal healing process with the hemorrhagic inflammation of the soft palate occurs in about 30% of all the patients who have undergone tonsillectomy. Of these, secondary hemorrhage occurs as a complication in 16 to 33% of the patients. This is his patients. It's not a study. He's just doing a case series. So if you go through the paper, he makes some very important inferences. So he notes that the incidence of this complication is practically negligible in Europe. How he came to this conclusion, he just read some books from European literature, and no one had ever mentioned this complication. And he notes that the methods of operation and techniques employed in this country, the US, and in the Europe are the same. It appears obvious that the difference in the post-operative course is due to some other factor. And then when he compared the post-operative and the preoperative regimen, there's only one significant difference that he could find. And in the US, there was a practice that they would give 0.65 grams of acetylsalicylic acid 3 to 4 times daily to the patients after tonsillectomy, just to make them comfortable. So he concluded that aspirin was the cause of increased bleeding in these patients. But what's interesting, if you go through the history of aspirin, aspirin has been for centuries. It was first developed by Reverend Edward Stone in 1763, where he used the willow bark as an antipyretic. And then Dr. Joseph Buckner identified that the active ingredient was salicin. And then Felix Hoffman in 1897 synthesized the acetylsalicylic acid in pure and stable form. And then Bayer patented it in 1899. So aspirin had already been in circulation and one of the most widely used products, but no one had noticed, no one had mentioned about the bleeding. It's only after 40 years of aspirin patent, filing of the aspirin patent, that Dr. Rudolf Singer wrote about bleeding complications with aspirin. And then this was published in 1948. And in 1948, Dr. Paul Gibson, this was 8 to 10 years after Dr. Singer gave his inferences, that he proposed another use case for salicylic acid and bleeding relationship. And then he published this report, salicylic acid for coronary thrombosis, ? Because no one had thought about it at that time. And then he was the first one to propose that, oh, we can probably use it for coronary thrombosis. I read his paper, and the way he proposes it is interesting, to say the least. He says, for though it is easy to imagine the gradual occlusion of diseased artery by accretion of platelet aggregation, it's difficult to understand the sudden development of local fibrous thrombosis. No one knew about plaque rupture during those days, so it was still a mystery how coronary thrombosis was happening. And then he goes on to say that in the treatment of coronary thrombosis, dicumarol, it's a naturally occurring vitamin K antagonist. So think of warfarin, but occurring in nature, is steadily gaining favor, but its dangers are not fully understood or controllable. It is thought to act by preventing conversion of vitamin K into prothrombin in liver. Thought, because they still hadn't discovered it. And then he says, I would suggest that at least until we know more about decumerol, we might use salicylic acid for the treatment of coronary thrombosis. It could do no harm, might as well do some good. So he says, this is like a verbatim from his paper, says it is probable that the idea of substituting salicylic acid for decumerol in the treatment for coronary thrombosis occurred to others. So I venture to cast my bread upon your waters in the hope that I may see it again after many days. So there was Dr. Paul Gibson in 1948, but people still didn't buy it. Even after Dr. Singer published it and Dr. Gibson proposed it, they still didn't buy it. It took them another 26 years that people started talking about aspirin in coronary artery disease. And the first trial was then published. This was a randomized controlled trial for aspirin in secondary prevention of mortality from myocardial infarction. People who had already had MI. And this is enrolling the patient after they had MI. And what they concluded was that they did not find any statistical significance. So it was inconclusive, a trial of over 1,200 men. But what they said was, nevertheless, they showed 12% reduction in mortality at 6 months and 25% at 12 months. And they did show us the survival curves. It looks impressive visually, but it was underpowered, or they don't mention exactly how they calculated and the theories behind it, but it was statistically inconclusive. But this particular trial ricocheted the investigation into aspirin in coronary artery disease. And then the two pivotal trials that were published after a century of aspirin being patented were the VA trial and then the ISIS-2 trial. And they were the first trial, the first trial that was published was the VA study. And they did a sequential analysis where each patient receiving aspirin was paired with a patient receiving placebo based on the entry date. And they looked at the differences in survival in these patients. And it showed that there was significant benefit of death from acute myocardial infarction, fatal or non-fatal MI, and then a non-fatal acute MI as well, and death as well. So improvement in these outcomes. And the ISIS-2 trial also showed that compared to placebo, aspirin one thing I forgot to mention, the VA study was on unstable angina, whereas the ISIS-2 trial was people who were suspected of acute MI. And it also showed that aspirin had significant benefit in these patients. So in conclusion, but some of the major medical and cardiovascular discoveries have been made incidentally and serendipitously. Keep an open mind that important finding may not be the one that you're looking for actually. And then one can learn a lot from Miss America pageant. Thank you.
Let's come up and take questions from the firing squad. From the faculty. Any questions from the group? So I think,
Yeah. So first of all, I found both very interesting presentations for different reasons. So maybe a question to Imran first. So, I think you approached your analyses of the data, and it's from the perspective of positive, of identifying productive ways to teach residents and others. But did you collect any information on kind of the negative experiences? In other words, did you identify any conditions or experiences where people felt that they were more confused, or actually that there were more that led to worse or more uncertainty in how to manage the condition. So it's a difficult question, but I'm just curious if you can give us any guidance from this experience on things to avoid. Yeah. Yeah. In what ways are we confusing individuals, I guess?
So this is actually a great question, and I don't think we explicitly asked that. I wonder if in any of, I guess, our faculty surveys or MedHub evaluations, I wonder if there's anything in there that might help answer the question. But we did not explicitly ask that. But that's actually a great idea in terms of follow up, what we could do and avoid in the future.
Yeah, and then Savine, I mean, I'm a big student of history, so I learned actually a lot from your talk that I wasn't really aware of. So I'm curious, have we, in terms of your perspective of the medications that we are currently using for the top conditions that Imran shared with us, we need to teach people on. Do you have a sense of would you give us a guess, Demet, based on your assessment of these serendipitous findings? How many of those medications do you feel, what percentage of those medications are resulting from these kinds of experience where studies were conducted for a certain reason, but led to a different path? I mean,
Yeah, I don't have a number in mind. It's probably less than 5% because you don't have breakthroughs in medical sciences anymore, which are serendipitous, but it's more of a historical thing where the methodologies were a little bit more different and the protocols were less stringent. So the research had a way of working out stuff, and based on their laxed methodologies, they would find stuff that they were not supposed to and ended up changing. Things that come to mind would be, like beta blockers for arrhythmias initially were developed for hypertension only, and that was one of the findings that they had. Aspirin that I presented used a lot. In my preliminary research, statins also came up as one of those drugs where the only initial thought was that they were lipid-lowering drugs, but they ended up having more significant cardiovascular outcome benefit because of not well-known anti-inflammatory properties with the plaque burden and plaque thrombosis. So those three do come to mind, and those are actually one of the most prescribed medications that we use in our practice. So from a sheer number standpoint, quite a bit based on the number of prescriptions, but individual drug-wise, probably, I want to say 5%, maybe less.
Yeah, I know you didn't want to talk about AI here.
Yeah.
But arguably, maybe your perspective is influenced on the expectation of finding large effect sizes, right? And so now we're in an era, I would argue, where we can actually mine the data for small effect sizes, and where we could find different types of serendipitous findings based on the accessibility of large data sets to look for these smaller effect sizes. We might not see a 30% bleeding change, which you could observe in a handful of patients or someone's personal experience. But arguably the tools that I know you've been working on and others allow us to maybe change the paradigm for those serendipitous findings from large data sets.
Yeah, to give you one example, so one of the projects that I worked with Rohan and Harlan was developing risk prediction using machine learning for HFpEF population, and we used data from TopCat trial. And it was interesting that we thought initially, the hypothesis was that the biggest risk factor for the hospitalization based on the data would be either age, or socioeconomic status, or the medication burden, or and then kidney disease. So those four were our primary risk factors that we thought would be really important. They were not even in top 10. The top three were KCCQ score, which is the quality of life assessment, KCCQ physical limitation score, and then KCCQ burden score. So we didn't expect just patient-reported outcomes to have such a huge impact on the future events, but that was one of the findings which was serendipitous that we never expected for just those factors to have such a huge impact on HFpEF mortality and hospitalization. So that is true because we've seen that in our studies as well. And I'm sure with what Cards Lab and people at Stanford are gearing up, you'll see more and more of those things in the future. Yeah.
So terrific presentation, both of you. This is maybe a little bit of a qualitative commenting question, but I would say that in basic science research, it's extremely common to have unexpected findings. And so I give talks on serendipity, actually. I mean, I can have that discussion with you later. But some of the, biggest discoveries, and you mentioned some clinical discoveries, are made just serendipitously, and they've led to new pathways of research and a lot. And so I guess the question would be, and we're all aware of that. And so if you do very basic molecular work or using genetic models of animals in preclinical studies, whatever, you're always finding unexpected things, and you want to pay attention to that. I guess the question in clinical trials and in patient studies, how often does that happen? And I guess the second part of that question is how closely do people pay attention to unexpected findings? I think they probably do, but I don't know, how often that comes up, because it's very common in basic.
I was expecting that question with basic science. I'm not a basic scientist, so I tried to steer away from basic science studies in my presentation. Yeah, because it's difficult to answer questions if you're not, well versed with those methodologies. But it's true that the basic science research has, some of tremendous serendipitous findings which have been important. To answer your question, the proportion of the studies that have serendipitous finding clinical studies, I'm not sure. No one has actually looked at it. Even when I was doing the literature review on my presentation, it was difficult to come by, to say the least. And most of the studies that I found were historic studies. Only two important studies that I found were the SGLT2 inhibitors, of course, and the Viagra study. Those two were more clinically impactful, but those two were the only clinical trial studies and clinical studies that I could find in the last 4 decades. I'm sure there are some, but they haven't changed our clinical, or they haven't been as impactful for our clinical practice as much. Much more in the olden, almost like 50 to 100 years ago, the studies that were coming out then are actually much more, have like that serendipitous nature to it. And also it's difficult to find cardiovascular studies, because most of these studies that I was trying to find were mostly non-cardiovascular, like cardiology studies. So it's also difficult to say, but within cardiology, very rare. I only found 2 in the last few decades. More were in the historical. Yeah.
One quick, I kind of piggyback off of Dr. Bender's comment, and I guess more so for the future, as we implement AI to design trials, I think largely trying to optimize for baseline risk and certain phenotypes that you want enrolled in these trials, all the way to data clearing, training data sets, sort of clearing out noise, if you will. Over time, do you think, if we're not looking for it, as Jeffrey mentioned, over time, do we run the risk of generating, a lot of homogeneous data as we get better and better at doing these trials, and essentially missing out on potential serendipity in the future?
Yes, because most of the training data set have been employing very certain, I want to say like methodologies when it comes to the algorithms that they employ. Uh, I know Rohan is doing one of those things where he's trying to extract out the heterogeneity in the clinical trial population and then see, can you personalize it more for like real world population? But he's working on that. I'm not involved in that project, but the idea is the same, that there is a lot of homogeneity in the inclusion criteria in the clinical trials. And if you employ a large scale algorithms that you're trying to extract out meaningful data, you may not be as successful as you would in a more heterogeneous data. But to answer your question, yes, it is definitely a drawback, and people are working on it.
My last question, Dr. Gallegos.
It's not a question. Well, thank you both for your presentation, specifically to Imran, who was a great help. He did a really good job with the curriculum, and also Natasha. You know, you guys may remember a couple of years ago when I took over the inpatient education as a response to our ACGME survey about education, we wanted to enforce and add, you know, material and time for teaching and good content. So I had initially started doing the slides on my own, and I realized that that was never going to happen. So I know how hard Imran worked and the rest of the team putting that together. So thank you very much.
Then I have the last question. So Imran and team, how do we keep this learning to be live and living? How do we keep it going to continue to improve and adapt and respond to the feedback?
So that's a great question. And I actually had a couple of ideas. So one thing that the fellows currently do and we're responsible for is, you know, teaching our other co-fellows through, you know, board preparation. And so one potential way that we could keep updating this, you know, year over year is assigning each fellow a particular topic that they sort of are the stewards for, and that they review, revise, and edit as they see needed. So there's only a handful of there's only a handful of topics right now, and probably even once, you know, we kind of get done, you know, we probably don't want more than 13, 14 different topics, because a good year rotation lasts about 2 weeks. And then if you factor in the fact that a resident's off one day and then an intern's off one day, you know, there's only so many days that you could really get teaching done during a rotation. So, you know, if we keep a library of about 12, 13 of the most common diagnoses and make slides for them, and then have one fellow each year be the steward or be the reviser or lead editor for that particular topic, then I think, you know, we can keep it updated year over year.
Great idea. Thank you both.